Welcome back to our, I believe, fifth lecture on epidemiology for the evaluation of intervention effectiveness. I always try to recapture a little bit what we discussed, what we review and cover in the past few days. So the course is intention is to stimulate you to be more courageous in evaluating public health interventions, healthcare interventions, treatment, new alternative treatment regimes, whatever you think it's appropriate to evaluate. I'm giving you lots of tools. Most of these tools are in the PowerPoint presentation, but evidently I provide a lot of literature I want you to read. Not only a list of reading, but also in each segment of the lecture, you're going to see a footnote with the citations and I have reference for you to read over. This is very important. Also, remind you again, this is not a course in statistics. Even though I'm presenting a lot of formulas and regression, it's just theoretical for you. I'm not a statistician. I'm a medical epidemiologist, and I feel strongly about methods and statistics, but not to the point that I'm going to teach you a statistical course on that. So it's just an introduction, and sometimes I gloss over the material very quickly to go to a more simple formula. And so this is going to happen in these two lectures for sure, like it did in time series, like we did in step wedge cluster randomized designs, so that you have the foundation, but then you need to have in your team, your research team, a statistician. And this is an important concept. The statistician, who is a trained statistician, ideally at the doctorate level, they are resourceful. They may not be an expert in these topics, but they will easily get to become an expert because they have the foundation to really understand what's going on as you present the formulas in this lecture to him or her. Okay? So on that note, let's continue today with the discussion on regression discontinuity. So similar to the time series, regression discontinuity take advantage of existing data out there to create some kind of a counterfactual, but it's different than the time series. The counterfactual in this case is actually a real group. I'll explain that. It's a lot of wording in this lecture because I want you to get the concept right, but there are some graphic representation. I hope you can get to it. And then we're going to cover difference and difference, which is also a similar idea around existing data over time and over across groups, possibly. So here are some of the citations, the literature I want you to look at. Remind you again where these regression discontinuity sits. It's in a quasi-experimental group. It's a form of natural experiment if somebody else implemented a policy or a new strategy and you just observing that happening and you want to evaluate, so it becomes a natural experiment. But it's in the quasi-experimental group of design, meaning you have control, some control, not you necessarily, but somebody has control over who gets the intervention, who doesn't. That's a very important point. But you do not randomly allocate that intervention, that treatment. If you allocate randomly, you are in the experiment types. Okay? So it's a natural experiment type of, but could not be. It could be you decide what the intervention is and you set up your series of data over time across groups, and therefore you'll be able to follow up. So again, the regression discontinuity design, it's a quasi-experimental that can be thought of as a natural experiment if another person, another group intervene and you just the evaluator who's going to evaluate. Okay, it becomes a natural experiment. If you yourself is doing the intervention and waiting over time to evaluate that, then it's a quasi-experiment. You see the distinction here? Okay. In its simple, most traditional form, it's a pre-post test program. It looks like, but it has a comparison group. Pre-post test is that the traditional pre-post test is that you have assessment at baseline, at pre-intervention to both treatment and control groups. Okay, and then you follow over time and do a post evaluation, a post test after the intervention has been implemented in treatment and the control group, and see if the outcome change as a function of the treatment. So that's what the pre-post test program is. The regression discontinuity looks like that. It also looks like a time series. I'm going to hopefully kind of distinguish that from the randomized experiment, from the traditional quasi experiment, and also from the time series as we go along. But bear with me. So in this design, participants are assigned to a program or comparison group based on the cutoff of a score on a pre-program measure. You already have a measure on this kind of intervention, on the outcome of your interest. You have some kind of measure of the outcomes, and also confounding variables and your intervention variable. And this measure, the intervention, can be considered, can be conceptualized as a score or an index in a scale, and then you create a cutoff on that. So it's only one group. It's not a two-group design. It's one group, but out of one group, you turn them into two groups. Let's do it. Let's see how more or less it looks like. I give you some examples of pre and post, post only, pre and post with control. So a regression discontinuity is going to look like that, but not quite. The representation graphically is going to be very similar to the one on time series. You see that here? Except that either the little dots before the program start and the little dot after, one is going to be a control group. Okay, so how do we do this? How do we do that trick? Let's explore a little bit more. Regression discontinuity exploit the fact that some rules are arbitrary and generate a discontinuity in treatment assignment. The treatment assignment is determined based on whether the unit exceed or not a cutoff point, a threshold. Assume other factors do not change abruptly in threshold. So if you change that threshold, I say after this point, I'm going to give you an example of a law. And we're going to see that clearly. A law is a law to say after 21, age 21, you can drink. And before age 21, you cannot drink. So when you do that, okay, so the law, it's about age, right? And age is a continuous variable, so you create a cutoff point. But the people before that cutoff, anybody who is 2019 is very similar in behavior to the people who are 21, 22, aren't they? Think about it. If I say my intervention is an intervention that's going to change the law regarding drinking, alcohol drinking in America, or in my state, or in my city. If you are age 21, you can drink. If you're not, you cannot drink. You follow that? So in doing that, you create just a scale. The scale is age, right? It's a continuous variable, or you treat as interval continuous variable, but it's actually a discrete number. So what you have is people who are 21 and 22 and 23, 24, until 100 years old, they can drink. The people who are 0 to 21, they cannot drink. Well, I'm asking you the question, are the behaviors of people, my outcome in this case is drinking itself or car accident due to alcohol intake? Okay? Car accident due to alcohol intake. So what caused the car accident when you drink alcohol? The drink of alcohol impaired you, right? But drinking is a behavior, right? So do you think that behavior is different between a 20 years old and a 21-year-old? It's not, it's the same. They're in the same age group. They are past kind of a teenage, but they're still kind of a teenage, right? So there's no difference between being 18, 19, 20, 21, 22, 23. Maybe you're getting to become an adult. If you're a man, we extend that to 34, okay? But the point is, these groups are very similar in every aspect, except that there's a law that says 21 you can drink, before that you cannot. So you create natural comparison groups. You follow that? They are comparable in everything but the law, okay?
So that's what this regression discontinuity is all about. I'll give you that example later on. Regression discontinuity is a quasi-experimental evaluation option that measures the impact of the intervention or treatment by applying a treatment assignment mechanism based on the continuous eligibility index, which is a variable with a continuous distribution. In this case, was age. And age was associated with the intervention because the intervention is a law, but the law has the age as part of it. So you use that information to create a cutoff and say, hey, you are treatment group after age 21. And before that, you are control. Or vice versa. I say treatment is control. 21 above is control, and 18 and not, it's not control. You follow that? So you create natural comparison groups. So again, a regression discontinuity design is appropriate where, this is very important, a treatment intervention or policy, a law, is given to individuals for whom some measure characteristic lies on one side of a cutoff. There's a sharp, there's an immediate cutoff that create a regression discontinuity. So if I look in a time series, if I just look at the time series, remember the time series lines, you can see that goes down vertically. It was going one direction, one slope, let's say it was going positive from left to right, it was going positive, meaning the slope was positive. And then after this law is passed, immediately it goes down vertically. The next point after the law, it goes down and continues in a slope that could be exactly the same, a little bit lower, or continuously going down. That's a time series, right? But here I'm in a regression discontinuity. So it's not just a continuous point. The people before my control or my intervention and the people after my intervention or control, whatever I want to define them. Okay? And more important, the characteristics cannot be perfectly manipulated by individuals. They cannot manipulate the law. The law is the law, right? In this case. So a scala variable, age in this case, is used to decide who receives treatment, who does not. Well, that's very simple. In the law, everybody after 21 receives the treatment or the intervention. Okay? They can drink. The intervention is that, yeah, I'm free to drink. An arbitrary threshold is used. Observe outcome just below and above the threshold. Those who are just eligible will be very similar to those who are just ineligible because they're all close to the cutoff point. I mentioned that before. It mimics randomization that way. So here, what I call the eligibility criteria, that cut point. So it looks like a time series, but it's not. Okay, just think about that. So another way to represent that in this example here is another variable which I forgot to look at. But let's say this terminology used here, these acronyms C and O, okay, it's just to indicate there are two groups created once you get the cutoff point. Pre, in this graph here, pre means any continuous variable that correlates with the outcome of interest. Okay, any continuous variable that correlates with the outcome of interest. It could be, in this case of the law, the outcome of your interest, in this case, could be car accident due to alcohol drinking, violent behavior after drinking, lots of outcomes that's associated with drinking alcohol. Okay, so your pre-variable in this case was age, was actually part of the law. It was very easy to define that. Assignment based on cutoff score, regression line should have vertical displacement at the cutoff score if there is an effect. So you'd see a vertical displacement. The blue line is going on a slope, and immediately after the blue line, that slope goes down to the green line. Okay, that's a vertical drop. Okay. In this case, I call the left one treatment and the right one the control, but it could be the way around, doesn't matter. Okay, it depends what you're looking at. This is not time, folks. This is just the values of the pre-variable, which I should have looked at that. What was the example here? Clearly that was in the post test. So that variable is measured before in post, and you can see the change in the group. So if there is a treatment effect, there will be a discontinuity, like the vertical red line.
in the regression line. The regression line should have gone straight and gone down in a way similar to the time series, except this is not time in the x-axis here. It's not time. It's the variable that you're looking at. In this case, was age. Let's take about age. Here's not age. It's another example, but I could not find a graph for that. Later on, I have a little bit more on that example of the law that Dr. Ramos missed on alcohol drinking after age 21. Okay, and here's the cutoff point. So assignment and target variable. So you have your treatment effect is expressed by this difference. Okay, your assignment and your target variable change. You know, as you the dotted points is the control, the blue one, the red are the treatment. In this example, you can clearly see that something went up, you know, over time. So that's what you call a regression discontinuity. And because I'm calling a group treatment control, you create two groups. For instance, the time series is what you cannot do that. In a time series, there's no such a cutoff that I use to say this is treatment, this is control. It's just looking at the outcome, the Y variable over time. And we looked at over yesterday in detail. Here, I'm calling each group a different, and this is not time. Assignment variable at the bottom is not really time. And the example I gave is age. It could be something else. So in most research, we wish to have comparison groups that are equivalent to program groups on pre-program indicators so that the post-program difference may be attributed to the intervention itself. But because the cutoff criteria, programs and comparison groups are deliberately and maximally different in pre-program characteristics and apparently insensibly anomaly, okay, insensible to anomalies. And that's the example I gave it to you that I describe it. Here's the example. In America, 21st birth is a very important milestone because over 21 can drink legally. Back when this law was passed, a lot of studies came out. One of them was this Carpenter and Dopkin, a group of American college presidents, the presidents of the college, the universities, have lobbied the states to return the minimum legal to 18. They believe that legal drinking at 18 discourages binge drinking and promotes a culture of mature alcohol consumption. The minimum legal drinking age of 20 will reduce youth access to alcohol, thereby preventing some harm. Which one is right? So the two groups, one saying it should be 18, these are the reasons. The other one say, no, 21 is when you really prevent harm. So they did a study, and that was the example I was trying to give it to you. This is days from birthday. That's your, remember the terminology I'm using here, assignment variable and target variable. So the assignment variable is days from birthday of 21. And here, number of death. You see number of death on the left here? The y-axis is number of death. The x-axis, days from birthday. So you can create various lines, like this line, which is kind of a light line with a kind of white dot, is the 20th birthday. That means the person just turned 20 and is 20 until they turn 21. So for 12 months, they are 20. So I look just at lines for these folks. Then I look at the line of 21st birthday and the lines of 22nd birthday. So 21 and 22nd are what? Treatment group, right? Or control, whatever you want to call it. In the other group, the before the 20, they are the control or treatment group. They are different. So two groups here are in the after the cutoff, and one group is before the cutoff. So what do you see? You see that the 21st birthday group, that's the one the law took effect, as well as the 22nd birth, their rate of death are kind of higher. You see what I'm saying? The death rate is higher. Whereas the one that was 20th birthday, that's like within the regulation, they are not. So bottom line is they're different. The results are different for these two groups. And that's how you display a regression discontinuity. There's a lot of math I'm going to show it to you. Don't want to get too much into that. I can do it, but I cannot explain too well. But we're going to go over some of the equations. But how do you explain that if you do not have an effect? You would expect an effect. So the cutoff criteria implies the measure advantage of the regression discontinuity over a time series study. They are appropriate when we wish
Sometimes we have no option, have to do a time series, which is pretty good too. But here, when we wish to target a program of treatment to those who need or deserve it, those who need or deserve, when you're in doubt if that thing can be beneficial, you should not do regression discontinuity. Thus, unlike randomized or true quasi-experiment, the RD design does not require us to assign potentially needy individuals to a no-program comparison in order to evaluate the effectiveness of program. The law was created, I'm observing it, it's already creating the natural comparison group. How I define that is based on a scale variable. You see that? That's the beauty of it. There are some assumptions, I'm going to show the math of it. Treatment is assigned on the basis of observable variable index, so you have to have such a thing. If you don't have it, you cannot do it. There is discontinuity, that's the expectation, and the probability of being treated or intervened at some cut point. We showed that on the death, the total death, before and after 21. The cutoff value of the index treatment is arbitrary, and thus units on either side of the cutoff are identical on average, except for the presence of treatment, especially those very close to the cutoff point. As you move away from the cutoff point, you become very different for some other variable. Not for that law. For that law, really, once you are kind of supposed to be of age like 18, you can kill in America at 18, right? You go to army, you can shoot. But you cannot drink. So that was the question too. But then between 18 and 21, you are very similar to people who are 20, 21, 22, 23, 24. There's no difference between them. They are very young, late teenage or very early adulthood. And the behavior is the same. I still remember in my 20s, and it was not different than my teens. I did the same stupid things all the time. The same cutoff is not used for determining eligibility for multiple treatment. That's something else. Households, for example, below a certain poverty line have access to multiple government interventions. That's a program. You don't use regression discontinuity for that. So again, just to remind, pre-post test two-group design. Without having the two-group, you create by doing the cutoff, using a scale variable, an index variable, a score. The term pre-test implies the same measure is administered before and after some program or treatment. In fact, the RD design does not require the pre and post measure are the same. Okay, you can have, remember the scale variable and the one I'm measuring the outcome. Let's go. There's a lot of wording here. We're trying to be good in time. See if we can finish this in 30 more minutes. Two group versions. This is the important point of the RD design. Might imply either that some treatment program is being contrasted with a no program condition, or that the two alternative programs are being compared, meaning there are two, it could be also two interventions. You don't need to say treatment and comparison. You can be two interventions. One that's already going on, you create another scale variable associated with the outcome, and then you do a cutoff on that, you compare two treatments. The description of the basic design as a two-group design implies that a single pretest cutoff score is used to assign participants in the program or comparison groups. So comparison can be control or another treatment. The term participant refers to whatever unit is assigned. In many cases, participants are the individuals that they could be any definable unit, such as hospital wards. So you need not to have a person. It could be just like we saw it. The example on death is actually a rate. It's a whole city, a whole county, a whole state. The outcome is an aggregate measure. So you can do that at an individual level or aggregate measure of all types. The logic of that, selecting cutoff, what's the logic? Assignment based on a cutoff value, as you know, on a pre-program measure, you have that pre-program measure. In this case, what was the pre-program measure of a law on drinking age? It was age. It exists. It's a you have that measure. If you don't have a pre-program measure, you can't do that. So they have to have something related to the program that you can't cut off people and create two comparison groups. The cutoff rule for simple two group is essentially all persons on one side of the cutoff are assigned to one group, all persons on the other side are assigned to the other. It needs a continued quantitative pre-program measure. So these three conditions have to apply. It should be logical, right? You can read that. Let me just maybe the example, maybe I need to read to you. Selection of cutoff can be based on the program resource that are available. And this is a good example. If a program has the capability of handling 25%, 70 people apply, one can choose a cutoff point that distinguishes the 25 most needed person from the rest. You see what I'm saying? I don't have resource for everybody, so it's ethical in a way. I will only intervene in 25. The others 55 will be my kind of comparison group. Alternatively, the cutoff can be chosen on substantive ground if the pre-program assignment measure is an indication of severity of illness, measure on a 1 to 7 scale. This is an example, folks. It's a made-up I created, I think. It's a long time. And physicians and other experts believe that all patients scoring 5 or more are critical and fit well the criteria defined for the program participant, then cutoff value 5 may be used. So in that way, I create below and after the cutoff from 1 to 7. It could be a depression scale, PHQ, Luis. Okay? Could be a depression scale, and then you do something like that. What else? Again, that terminology, just to guide you again, that's sometimes presented like that, regression discontinuity group. The C here indicates the groups are assigned by means of a cutoff score. So C is the cutoff score. In the age example in the law for drinking, the cutoff score was 21, the age by which the intervention starts. Okay? The intervention means you're free to drink. Okay, there was another interesting study. It was never published. A friend of mine did, at least mentioned to me he did. I have to confirm with them that he said, okay, what's the age kids go to university in America? 18. So he designed a study to evaluate their sexual behavior after 18, because they live with their parents until then, and then all of a sudden they are sent to university. There's 5,000 to 40,000 men and women alone, each one in their room or sharing the room, parties every night, going crazy. So there's a change in behavior, right, associated with age. So age becomes the cutoff point for that design. So a 0 here, it stands for, or a big O, for the administration of a measure to a group. That means I'm giving an intervention to the group. X depicts the implementation of the program, and each group is described on a single line. So program group on top and control group at the bottom, because the top one has an X. X is the intervention. So you have a group of 0 people, and then one group receives X intervention, and then we evaluate the 0. I'm going to call C and O. So C and O, big O. So you have your outcome, that's your big O in 2 groups. And then you define the other group as an X. It's very similar to a quasi-experiment, except that this is created by a scale, by index, that create the 2 groups. So treatment assignment variable is X sub I in this notation. Threshold cutoff. By the way, I'm going to show various notation for the mathematical equation for this regression that you're going to evaluate. Is usually very good to evaluate scores and continuous variables in general. But could be also dichotomous variable. So you have this terminology, but I'm going to show one initially, and then I'll modify it to another one that has a little simplified version. You'll see that in a few minutes. So your assigned variables, your X sub I meaning each individual unit of analysis here. The threshold for assignment is C. The treatment variable is D, and I, again, is the little I is the identification of each unit of observation measurement here in this case. So treatment assignment rule is that D sub I, okay, equal 1 if X sub I is greater or equal to C, right? C at the cutoff score. Cutoff on the score is C. So if my value of XY, which is an explanatory variable, is greater than C or equal, then D sub I becomes 1. If it's less than C, D sub I continues to be the 0 that we had before, kind of. Okay? You following that? So potential outcomes for an individual I with treatment Y with treatment. So I'm talking about the individual Y1 sub I, because there'll be values, there will be ones and zeros for different individual. One individual, in this case, individual may be a person, folks, but it may be a city. It may be a measurement that is general for the whole city over time. Okay, it can be anything. Potential outcome for individual without treatment, that's Y sub 0. So Y sub 1, Y sub 0 indicates that you have treatment or not. So observe outcomes, Y sub 1 if DI equal 1 greater than C, Y sub 0 if DY is less than C. So you end up with a regression discontinuity model, basically. You have your outcome variable, in that case was death rate, right? Beta 0 is the value of that death rate when treatment and the scores are null, a 0, right? Remember from linear regression? Y equal A plus BX, which A being the intercept, the value of Y when X is equal to 0, remember? And the beta X, the beta represents the slope, which is the unit of change in Y for every 1 unit of change in X. And that's your derivative. And not surprisingly, all these linear regression equations should have that from statistic. I estimated by taking derivatives and by finding the maximum and the minimum of the functions. Okay, so I'm not going to get into that. So you have beta 1 treatment, that's your beta, but here you have sigma score. Your score variable also enters here because it was used for you to create the cutoff. So if I don't treat like that, it becomes selection bias, confounding bias. So I put that also in the regression equation. And the E sub I at the very end is your error term, your generalized error term. So treatment equal 1 if score is less than 50, for example. Treatment equals 0 if score is greater than 50. In this case, I treat the higher value group as control or treatment 0, whatever. So this is called sharp RDD, but there's something called fuzzy RDD. So let me remind you what the sharp RDD is. Regression discontinuity. Nobody below the cutoff gets the treatment. Everybody above the cutoff gets the treatment. That's in that example. But even that example, I cannot guarantee in practice, right, that under 21 people don't drink. All the time they're drinking, right? And over 21, you can drink. And many people over 21 don't. I assume everybody drinks. No, I don't. But so sometimes this cutoff is really a sharp cutoff, meaning yes, no, drink, don't drink, but not quite. Because drinking can be classified as a fuzzy RDD. Why? The probability of getting the treatment jump discontinuously at the cutoff point, it's kind of a fuzzy. It's not a yes, no. Not everyone follows treatment assignment rule, right? Local randomized experiment with partial compliance around cutoff is a good example of that. Using initial assignment as an instrument for actual treatment is another possibility. But basically, I'm saying not all situations, remember, are not straight RDD, and they have implications mathematically in how you analyze that data. Okay, here is an example of either type. So you heard about it here in this lecture. I don't want you to be an expert on RDD. I just want you to be aware. Work together with statisticians. You'll be able to implement that, and a lot of policies and changes are happening every day in public health especially, or in healthcare system. A new protocol for 15 clinics associated with the hospital can be evaluated like that, folks, if there is a scoring variable that is associated with that protocol. So here you have on the y-axis the percent of households that participate in that whatever, and baseline poverty index. Remember the example I gave you? I brought that for economics, so it's really a program to increase participation of households in something. So the outcome is participation in something, okay? And the baseline poverty index was used as a cutoff point. And then you have an intervention that's associated with the baseline poverty index to increase participation. That's the whole scenario. So in that case, you would expect a regression discontinuity design based on the cutoff of 50 to have a sharp vertical change. That's your expectation. That's so-called sharp RDD, because there's a clear line between poverty, 50 and above, okay? But if people say, well, this poverty index People don't follow that. There's contamination. People goes back and forth. I can call this an RDD that is fuzzy. It's incomplete compliance. With complete compliance, if I can measure compliance, I can analyze as sharp RDD. If I don't have complete compliance on this cutoff, then I can use the fuzzy RDD kind of a estimation. And you can see that the baseline poverty index is the same. The incomplete compliance create also a sharp, but not a sharp decline usually. And the slope tends to be kind of a similar, maybe one slope is a little bit less than the other, but not quite. This is just graphic representation, not the truth. It's just a made up, folks. Identification of the sharp, the deterministic assumption is that once your cutoff goes up below above some point, you become 1 or 0. So it's a deterministic. The sharp uses more of a continuity, kind of, even though the score is continuous, but you have a sharp cut. But here they say, hey, this is actually, I would assume that people in between 20 and 22 are still kind of not in the treatment group. Only 22 and above are treatment group. So I can assign, even though the law says something. So this means that except treatment assignment, all other unobserved determinants are continuous at the cutoff C. This implies no other confounding factor affect the outcome at a cutoff. You only look at that treatment, okay? Any observed discontinuity now can be attributed to the treatment assignment. So whenever you have a fuzzy situation, you treat as a fuzzy as opposed to a deterministic sharp. Just remember you had that from here. So that's what you'd expect. The treatments at 0 as your comparison group, day 1 as the intervention group. So you have the expected value for your outcome, the example on death, remember, and the law. So you expect the death to continue like that. Looks like there's a line here. So you assume that the lines before is this dotted line. You don't know it, okay? But that's what you assume. This is the one, the real line before, okay, for the non-treatment group. So something that's beneficial. So your treatment you expect to be beneficial. So you expect, if they had the treatment, this dotted line on the top would be the continuation of that beneficial effect. And if they don't, so you expect this continuation, which you don't see it. That's your counterfactual. Should be continued like that. So you're estimating these differences. The vertical difference here is the effect of the RDD. Yeah, good point, Luis. Are they seeing the PowerPoint presentation here or in their screen? Like they are open a PowerPoint. How is that? Give me a second, folks.
They're watching just the way you're showing.
I know.
You can point on the screen.
If I point to the screen, would they see it?
Yeah, but not if you use the mouse.
They don't see what you're pointing in your screen.
I see. Give me a point. Let's see. This page is here. Yeah, it is. That's your stuff.
Yeah.
Okay. So, folks, sorry. Dr. Rum reminded me that I have a pointer. I hope you'll be seeing that because the camera is pointed towards me in the presentation, correct? Am I correct? So you have your regression discontinuity set up as you saw it, okay? And then you have your cutoff point. The expectation is your D0 is before the cutoff. The value, because this is a beneficial treatment, you expect that D0 is going to be at a level and with a slope. So you got D0 at some level and some slope. And then after the cutoff, you have this sharp change. It becomes the law, right? In the case of alcohol drinking at age 21. So then you have this vertical line between the initial line and the second line as a measure of the effect. So your expectation for the treatment group is on the full line on the top, and the expectation for the other group is reflected in this lower full line on the left that's continuous, a dotted point at the bottom. That's your expectation. But the only measurement you can really measure is this, and you have to adjust that through regression, okay? And that's what we're going to get into a little bit. So that's your effect. You see that? That's your y sub 1 minus y sub 0, given that x cutoff is at C. So that's your main estimation of the regression discontinuity design. Okay, you can read this. Let's construct a hypothetical example. Let's assume that this is more the area that you worked for like nearly 15 years, hospital administration. Hospital administrator would like to improve quality of patient care through the institution of an intensive quality of care training. So the intervention is an intensive quality of care training for staff. Because of financial constraint, the program is too costly to implement to all employees. So instead, you'll be administered to the entire staff from specifically target units or wards, which seem most in need of improving quality of care. So it's another way to say regression discontinuity is an ethical and feasible way to do an evaluation situation like that. Because the ideal scenario is that you randomize groups, everybody, into treatment or non-treatment. Okay, but here they say, okay, well, I don't have enough money, and there are clearly some wards in my hospital that are in more need for this training than others, at least anecdotally, based on my quality improvement performance evaluation of folks. Okay. Oh, it's not going. I have to use this. So two general measures of quality of care are available. The first is an aggregate rating of the quality of care based on observation and rating by an administrative staff member. We label that QOC. QOC. The second is the ratio of the number of recorded patient complaints relative to the number of patients in a unit over a fixed period of time, and we term that complaint ratio. So I have two possible Y variables here. The quality of care based on observation rating by the administrator, and the complaint ratio by the patients and others. In this scenario, the administrator could use the QOC rating or the complaint ratio as the basis for assigning units, but also to look at what the outcome is. Let me see how this scenario unfolds. Similar to the effect of the training, similarly, the effect of training could be measured on either variable. Okay? Shows for outcomes of alternative RD implementation possible under scenario. So they can be outcome variables. Regardless, let's say you use the quality of care as your pre-variable ratio, right? And then your quality of care becomes also something that you looked at, is that changing over time based on that pre, because I'm creating two treatment comparison group. Okay, so the first group becomes the program group, the other one becomes the comparison group. So what you see is a positive effect. Once I did that, the groups, this is not change over time, folks. Remember, this is not a time series. The graph looks like the x-axis quality of care, the y-axis quality of care. I'm sorry. Okay, so you see that vertical line here is the effect measure. So you really have this decline here, this sharp side. And the same can be said about complaint rate, okay, for a positive outcome. So for a positive outcome, your complaint rate is here, right? Okay, and you can see that, because here is a quality, you want it to be higher. The complaint, you want it to be lower. Doesn't matter where we put this, but you have a positive effect here too. You see the difference reflected, that positive effect. Again, this is not time. The x-axis is not time. Is the complaint rate, the same one as the outcome. Okay, is the cutoff create two comparison groups. This is the comparison group of this on the right hand side. So another example is the effect of new treatment protocol for inpatients with a particular diagnosis. I don't have the structure to do a randomized trial. And I'm in my own clinics. I'm not a researcher. I do a simple stuff, right? So for simplicity, assume that we wish to try a new protocol on patients who are considered most ill, and that for each patient, we have a continuous quantitative indicator of health that is a composite rating, which can take values from 1 to 100, with high score indicating great health, low score meaning lower health. We can assume the pre-test cutoff scores of 50 was more or less arbitrarily chosen for the assignment criteria, so that or that all those scoring lower than 50 or on the pre-test are to be given new treatment, while those with score greater than or equal to 50 are given the standard treatment. You follow that design? It's a very simple design. It can be used in your clinic. Oh, God. So in this scenario, yeah, in this scenario, you have the figure here, you have your regression line, the pre.
Don't get too away from the mic.
It's because I can't read well from here. It's very tough for reading. So you have your pre cutoff point of 50, and here you have the same variable, but now it's post, meaning it's later, okay? So you have the measurement before, and you cut them off, create treatment and control group, and then you have the post-test after a few weeks or month or year that you're observing that. So you can see the data points, and you can trace a line here, and you can trace a line here, two separate lines. Actually, I could unify the 2 points to look like a straight line, okay? That's your regression line. So show the hypothetical bivariate distribution. Each dot on the figure indicates a single person pre-test and post-test scores as pre-test in blue, post-test in green. The blues to the left show the program case. They're most severely ill on both the pre-test and post-test. Okay? They're severely ill here. They continue to be severely ill after. The green circle show the comparison is comparatively healthy in both measures. The vertical line, the pre-test score of 50 indicates a cutoff point. That's a vertical line. The solid line through the bivariate distribution is the linear regression. The distribution depicts a strong positive relationship between pre and post-test. In general, the more healthy a person is at the pre-test, the more healthy they will be on the post-test. And the more severely ill a person is at the pre-test, the more ill they will be on post-test. So meaning your treatment had no effect. Okay? God. Another 15 minutes. Now we can consider the outcome might look like if the new treatment administered had a positive effect. So compare this graph to this one. So here, there was no effect. Here, you have an outcome that might look like if the new treatment is administered has a positive effect. We will assume that the treatment had, again, simplicity, had a constant effect. That's another assumption. The effect is constant, doesn't change over time. You know treatment change over time sometimes. Not only treatment, its effect. Best example, tadalafila and erectile dysfunction. If you take one pill before a 10 milligram or 20 milligram, you know, you're going to have an erection within 2 hours if you have excitement. But if you take a 5 milligram pill every day, that's changing over time and accumulating. And at the end of 5-6 days, you have enough to have a measuring effect on your erectile function. So not all medication works like equally all the time. Sometimes they have a cumulative effect. So I just wanted to be all right. In this design here, I'm assuming the effect of treatment is constant. So we assume the treatment had constant effect, which raised each treated person's health score by 10 points. So the 10 points continue there. You know, again, this may not be true. I just gave you an example of tadalafila, but I can bring tons of other examples of the cumulative effect, have a higher or less if you're taking drugs for mental or for nervous breakdown, something over time, the effect gets weaker, right? So you need to understand that. That's a major flaw. So this figure is very similar to the figure before. Actually, it's figure 11 versus figure 10, not figure 1. Except that all points to the left of the cutoff have been raised by 10 points on the post-test. So you can clearly see the effect. The dashed line in figure 1 shows what we would expect the treaters group regression line look like if the program had no effect. So the dotted line showed the effect, the green dotted line, if there was no effect. So you continue from here to here, the same thing. But in fact, there is a real change. The blue are higher than the ones at the bottom, the green. Okay? Contrast that to this, in which if I am severely ill at the beginning of this study design, later in my post-test, I will continue to be severely ill. If I'm okay in my severity of disease score at the beginning of the study, and at the end, I'm still okay. So nothing changed. That means the effect had no treatment. But when you see a discontinuity of the regression line, that's called regression discontinuity. That's when your effect is estimated. Okay, so this is a very good design for this type of example I gave it to you. In clinics, you only evaluate new treatment protocol. If you have a strong effect, if it's really strong, there's a lot of bias. We're going to look into that at the end quickly. There's a lot of potential biases here. But if the effect is too strong, you say bias alone could not explain that. Likely the treatment has an effect. So now I have justification to ask for a scientific foundation or the Minister of Health or CNPq or whoever for money to do a real clinical randomized trial. This is very expensive. This is cheap. It's my patients. I have the enumeration. I have the electronic health record. I can initiate a new treatment. Ideally, something that's not known not to be toxic, known to have some effect. I say how effective it is with my regime that I'm already using as an adjuvant or something. And then I can do ethically this inside my clinic and do an evaluation and write a nice short paper on this. I'm serious. This is not too difficult to do. Okay? So I hope these two examples I gave you over the past 10, 15 minutes exemplify how useful regression discontinuity can be, but also look out for public health laws and change in regulation. Regulations about drinking, regulations about food. The other day I learned about something here in São Paulo. What was it? A regulation. What was that? Something we were eating and say, well, there's new regulation.
Degree of sugar in food.
Is that right? Oh, no, salt. What was the laws?
Was sugar-free and salt high.
But how do they implement that law? I mean, sugar-free and salt high salt.
They made it, every packing has to make it very clear if it's high in sugar or high in sodium.
Okay.
It's like the cigarettes thing.
Okay. So look at the sodium thing. So there was a new law here in São Paulo that food and restaurants and bars and commercialized has to show and say this is high content sodium. You should eat very low sodium. Easily, you could evaluate that by looking at surveillance data on hypertension, self-reported or from clinics over time. Your surveillance data from Ministry of Health provides you risk behavior and chronic disease outcomes every month. So you could look at a 2-year trend after this law. You have 24 data points. It's a decent number. Okay. If they happen like in the US, I could easily use a 6 months to evaluate because we do every day. We collect data on this stuff every day randomly from millions of people in America and put in a data system called Behavioral Risk Factor Surveillance System. So I can do a time series and change on those laws and the change in hypertension. Does that have an impact or not? And I can do a discontinuity. Actually, it will be a time series in this case, but a discontinuity, you basically assign, you have to have measurement on the pre and out score. I have to think about how we can create that. But there are opportunities there. In clinics, for sure, I gave very good example. It could be any medication, folks. But in public health, have to think about a realistic scenario, and I'll do that before this course is over on Friday, I promise you. It is sometimes difficult to see the forest from the trees and this type of bivariate plot. So let's remove the individual data point and look only at the regression line. The plot regression line for treatment effect, case of figure 1 and figure 2. Okay, so you can see that the cutoff point is here. Always remember this regression discontinuity. And this graph here, it's not time, it's pre and post. The same variable used to create the discontinuity is the variable used to evaluate the outcome. Okay, it could be a different variable like we had in the alcohol stuff, or death rate, but usually you can do like in clinics here. Okay, remember the example we had before, and here, in this example, hypothetical, it was a clinic, right? The score was severity of the disease I'm trying to change with my intervention. So that severity score is used to be the cutoff and to be the outcome that I'm interested in, pre and post test measurement. That's the ideal scenario actually for regression discontinuity. Okay, I'm not going to be able to cover everything. Another 10 minutes, folks, right? I have 10 more minutes, Fred. Is that right? What else can we go over this? That's the example I was going to give it to you early on. I gave you on alcohol at 21st birthday, right? That's the regression discontinuity. Here, the age group is the scoring variable that you create a cutoff, but the outcome is different. In the example in the clinic, both the pre and post measurement are on the same outcome variable. You with me? Here is a little different. I have the age being the cutoff point for treatment and untreated, and then death rate for all cause per 100,000 is my outcome. And you can see that when I plot that data, this data, believe it or not, like this, okay, you're going to see the effect of the law, death rate from all cause per 100,000. So you're basically preventing death in a young group. Actually, this result, which is a true result, I put the publication, it's basically saying the law is very powerful. It prevents younger people from dying unnecessarily overall. Because this is an age group that should not be dying. It has one of the lowest death rates of all age groups. You remember death rate, how it goes in epidemiology in every country, every population? It's nearly what? Very small when you're born, the first, but it has a spike. Actually goes up a little bit on the first month of life, and a little bit on the first year, stays there. Goes down nearly to zero, stays there until you are age what? 15, 16, you start doing stupid things like drinking and driving. Okay? So then goes up, spike, continues like that, goes down a little bit, and start going down now in a linear fashion until you reach my age where I should be dead by Brazilian standard. Northeast, I'm from Pernambuco. Life expectancy is around 70. So, right? So, but here, that means the law had an impact using regress discontinuity. But also I have justification here to say why I would allow this other death. You see what I mean? However, meaning after age 21, I should have the law, no alcohol for anybody. So the law is basically saying no alcohol for anybody. But here, there's a flaw because I create a cutoff based on age. After age 21, I'm now seeing just the effect of the alcohol or the age of drinking law, but I'm seeing the effect also of other things, okay? Especially after age 23. So I cannot say, hey, I should prevent death after age 21, and then I should stop alcohol for everybody. If you continue that regress discontinuity study for 50 years, you're going to see that this difference disappear because the outcome is total death, right? So start age 40, lots of other diseases causing more death than accident due to alcohol. You follow that? So don't go in that trap to say, hey, this data is supporting for me to create a law that should be no alcohol for anybody, any age. It looks like that, right? But remember how I'm looking at the numbers here? I'm doing from 19 to 23 because this group is perfectly comparable. They have the same behavior related to alcohol and to drinking and driving and using guns and so on. They are late teenagerhood and early adulthood. They are the same people. Come on, guys. There are 5 guys here. No women in this classroom right now. Come on. Don't you remember? You were like that. You were the same guy at age 19 that you were at age 23. No difference. You start changing after you finish school, get a serious girlfriend and trying to do something more serious. And now it's changing. But back then, that's when you start getting serious. By age 30, you have some decent way of being an adult, where women are already adult at age 20. That's a huge difference. So anyhow, here's another, this is a spline because the person who was doing this analysis thought that a straight line will not be, so you can modify your regression. I gave it to you design to come up with a kind of a curved linear or spline type of regression. Here is the example, and that curve that you saw here is because we did a cubic term, okay? A cubic term for the age, okay? And to do a cubic, you have to do a quadratic too. So you have to do a sequence of polynomials. But that's beyond the thing. So the effect of legal access and mortality rate is determined by this whole variable here. Okay? You remember the whole variable is D1. That's treatment on treatment. Everything else just adjustment to the scoring variable. Here's the true result on this analysis from that paper. And you can see the effect, death due to all causes. You can actually estimate how many deaths you could prevent with the law. Another way, looking more specifically instead of death rate overall, I'm doing the death rate, but also saying what are the motor vehicle fatalities and deaths from internal causes. I told you that that's when all the causes start coming little by little over time. So it's mixing up with the death due to motor vehicle fatalities. Okay? So all of that. So that's a very nice analysis you can read over. I think we are running out of time. I want to give you 10 minutes of grace. But before I do that, just to remember, the fuzz is when I don't have a clear cutoff that I feel confident that's cutting off. So those green and blue become mixed up a little bit. Remember, green is treatment, blue is control, or vice versa. So in here, the cutoff isn't clear because there's contamination natural between the two groups. And I gave some examples earlier. So that's the only difference between the two. You need to be more careful with your regression adjustment. Okay? So you guys have been wonderful. Thank you. 15 minutes break. Welcome back, folks. It's 15 minutes over, maybe a little bit over. Now we're going to focus, you learn about regressive discontinuity, which is very much easier to use if you conceptualize that you have a lot of opportunities for doing that in healthcare delivery, in primary care especially, or any specialty. And in public health, there are many opportunities to apply that, especially with change in regulations and laws. You can create a natural control groups based on a cutoff. Once you have that, remember the people close to the cutoff point, they look alike. Remember my graphs of regressive discontinuity always shows like 19 to 23 because they're very similar. You can see the difference in the line. You have the discontinuity of the line because it represents program effect. If you don't have this discontinuity, that means zero effect of your program, a straight line between the supposed to be control and supposed to be treatment groups. So you have lots of opportunity. And clearly in healthcare, any protocol, treatment protocol, any strategy can be evaluated like that simply by having records. You know who are the people who you did the cutoff and say, these people are tough, these people are such. I can create a new data set just with the people who are treatment control and with their Y or the outcome variable measured before and after the intervention. And the after could be an intervention for 1 month, an intervention for 2 months, an intervention for 1 year, an intervention for 1 week, if it's a drug that has a potential effect in 1 week. Now we're dealing with a little different group. You have natural comparison groups created, and you're going to take advantage of that using a technique very much in vogue by economists. They've been using that for a long time, and they developed that methodology. I'm going to show you here one example of that methodology that I developed. I designed that study. We'll get to that later on. So I'm going to show you one main example here, but hopefully we can go through it. There's a lot of formula. I was carried away. We tried to skip that. I want you to read, because really it's not the intent of the course to teach you the statistics of it. Plus, I'm not the expert in that to give you that teaching, but at least give you an idea of what you should be looking at, okay? The next hour, we're going to cover this, and then after that, we'll take a break, and I'll cover one example of step wedge cluster design, okay? Actually, it's cluster design, because I think it's important. We didn't give you big example. I just noticed reviewing the lecture. We never fully finished that lecture, and then I went too fast. I want to give you good examples for you to understand how to do analysis of a cluster randomized design. So in difference and difference, again, I'm putting a lot of literature for you to look at. This is a typical design for quasi experiments to assess impact of intervention when you have comparison groups and measure the change in the outcome between pre and post in both the treatment and the control group. So think about treatment group pre, treatment group post, right? So the difference in the outcome for these 2 points in time for the treatment and the difference of the outcome of interest, the Y, for the control group or comparison group, pre and post, okay? So well, if I take the difference of the first group minus the difference of the other group, I'm taking a difference in difference, right? And I can go, actually, I'm going to show an example. There's difference in difference in difference. That's what I did later on. So let's look at some kind of a diagram to try to understand this. In a causal model, traditional causal model, you have an A treatment and you have a Y outcome. You also have something called confounder. Like I mentioned to you, there's a lecture on the first day that I did not cover, just mention. I want you to read that measure of measurement errors. There's measurement error coming out of statistical view of the error. That's statistical error. There's also epidemiological error, which are selection bias, confounding, misclassification bias, information bias, all kinds of bias I'm covering over there, okay? One is called statistical error. The other one is called systematic error. Once they are built in the design, you're doomed. You cannot understand what's going on because you didn't take that into consideration. Here you have the confound, which is the one that creeps in almost every one of the observation quasi-experiment. And even randomized design. So the confounding is a variable that's associated with both your treatment or your intervention, your exposure to whatever factor, and your outcomes. So it's related to both. But it's also a very important variable that's determining. You could write this arrow line between X and A as a two-pointed arrow. I mean, they're associated, but you usually have a kind of a prediction or causal kind of effect on the Y. So that's your confounding. A difference in difference model is concerned with estimating the average treatment effect, like I mentioned to you, okay? The expected value of the difference between treatment and control group, Y sub I minus Y sub 0, given that A, the intervention was implemented, okay? While somehow controlling for it, but without doing a randomization. Hence, we are interested in the causal effects of confounding on the trends and outcome over time, pre and post between treatment and control group. Therefore, for the purpose of drawing a DID causal diagram as it is, as simple as replacing Y with ATT, okay? And ATT meaning the average treatment effect on the treated, okay? So in a traditional model, the one on the left, I have A, the treatment, X, the confound, and Y. And here, I have similar, but instead of Y, I have the average treatment effect on the treated. So the confounding is taken into consideration indirectly. And again, remember the whole discussion after experiment about counterfactual. The counterfactual is trying to accommodate the confounding effect, especially in selection bias, so to speak. So the difference in different approach combine two counterfactuals to produce a better estimate of the counterfactual. And in that way, what you see is the effect of the treatment. So it's doing a before and after comparison and comparison between those who choose to enroll and those who choose not to enroll in intervention. Okay, two before and after. Note that the counterfactual being estimated here is the change in the outcome for the comparison group, the average effect of the treatment. Difference in difference, and difference in difference in difference, it's also possible. Before and after outcome variable for the treatment group are A and B, okay, that's before and after, respectively, while the outcome for the comparison group goes from C, before the program, to D, after the program. That's another way to represent. I'm using different terminology because there are different, each of the paper had a little different. I don't want you to be confused. It could be Y baseline, Y posterior, or Y follow-up, okay? I usually use the terminology Y sub B, which means baseline, and Y FU, which means follow-up. That's posterior. So then you have your treatment groups B minus A, and you have before and after, okay? Before the program, after the program, C and minus D. Two counterfactual. The difference in outcomes before and after the intervention is B minus A, and the difference in outcomes after the intervention between treatment and comparison groups is B minus D. Well, it should be C minus D. DD impact is B minus A, D minus C, or C minus D. So equal BE, where E is the supposed value of B if long-term trend of comparison group is applied to treatment group. We're going to break that down a little bit more. Read over. It's confused, but it's not. There's an error here. It should be C and D. Sorry. Faced with understanding the impact of policy or intervention on beneficial outcome for a group of people, a natural reflex, which appears too often in the public debates, to compare situation of people who have benefited from the intervention implemented with that others who have not. This is a typical, very political, very charged up scenario. Evaluate the effectiveness of unemployment insurance reform offering personalized job search assistance. One could thus compare those who benefit from this assistance with those who did not. There is a paper I mentioned here. Let's see if I have a better example that's health related. Somehow I use this paper. I'm sorry, folks. Well, anyhow, this study shows that unambiguous job search assistance lead to a much lower return to employment for those who have benefited from them. Does this mean that the services are detrimental to the probability of finding a job? Of course not. Alternative interpret people who are offered job search assistance are precisely those who have the greatest difficulty in finding a job. So this is an example in which you cannot, through a simple evaluation, make a statement because of this situation at the very end. There's an alternative interpretation. It's not the assistant program that's working or not working. It's the fact that people who offer job, search assistant, are precisely those who have the greatest difficulty in finding a job. So they're going to continue to have difficulty. They may be improved a little bit, but not sufficiently to become able to get a job. Okay, so you don't know what their start point was better. That's a selection bias. The ability of this method to measure average effect is not based on the hypothesis that no beneficiary can serve as reference for the beneficiary. It is based on the fact the absence of the intervention. In the absence of the intervention, the average evolution of the outcome for the individuals in the treated group would have been the same as the observed in a control group. So you expect parallel trend assumption. If you don't find that, you find evidence that the program is working. So in a way similar to the idea of time series, that the line doesn't change, or regression discontinuity, the line for treatment and control groups don't change, continue to be a straight line. Here, you're looking at parallel assumption. The parallel assumption, the line for the control and the lines for the treatment group are parallel. They're not exactly the same because they're two different groups. Naturally, they have different numbers from the start, but their slope is the same. Therefore, the lines don't change. The assumption is the HO, the null hypothesis, there's no change in parallel lines before and after. Okay, so that's what the whole assumption. So you can then evaluate things like the one I just gave an example for. So we consider two groups. We observe both groups before and after the policy, for example. We can recover the average treatment on the treated if we assume parallel trend, which is equivalent to one of these two definitions. Suppose the difference between treat and control are constant on average, and suppose groups are on the same path. They don't change path, and the effect is constant. So you have parallel lines. I'm going to show the line very soon. The before and after difference remove the common evolution between the two groups. Like I said, the double difference identify an average treatment effect. The condition 1 and 2 are called the parallel trend assumption, the one on the top. Difference between treat and control are constant on average. The difference is kept constant before and after. And suppose group are on the same path. They don't change path. Whatever is the path I'm looking at from the treatment and control group, the conditions are similar, so they have the same path. So we are in a scenario of doing the difference in different type of treatment. Outcome measure identifies pre or post and identify a variable for each individual. So these are the conditions you need to have. Outcome measure before and after, and identify a variable for each individual. And situations where the predict outcome should take into account the various population characteristics. These variables can be included in the model and then used to adjust predicted values. So baseline is you have your treatment and non-treatment group or treatment comparator, but also you look at all the variables like age, sex, and throw them in your model to identify the change, the departure from the parallel aligned assumption. The simplest DID model are used with continuous outcomes. A change in continuous outcome more easily interpreted. The model can be used with binary outcomes, though. The interpretation for binary is a little bit more complicated. Analysis can be interpreted causally because association can be interpreted as DID is an ideal design for pre and post analysis in observational studies, not a quasi-experiment itself, because usually taking advantage of existing data, but it could be out of a conceptualized and a quasi-experiment that others implemented, because researcher does not control the intervention. I don't. So, but so here you have your parallel line assumption, right? The dotted line is the parallel assumption. The red lines are one group compared to the other. I'm using another terminology. The outcome treatment is by P. The P line is treatment. The control group is the S line. Okay. You can clearly see the expectation for parallel assumption is Q, P1 to Q, but then you go P1 to P2. Okay. So the treatment group then receive or experience the treatment on both groups are again measured at time 2, time 1, time 2, and vertical lines. So you have your time 1, time 2. You have your treatment group here from P1 to P2, the expectation based on parallel line assumption of the difference in difference is that P1 is going to go to Q, and S1 will continue as it is because that's a control group at time 1 and time 2. But then instead you have P2 here. So not all difference between treatment and control at time 2 can be explained as being an effect, because the treatment control group did not start out at the same point at time 1. At time 1, they do not start at the same point. So not all the difference that you find between treatment and control can be explained as just being totally effect of the treatment. So we have to disentangle these other effects. So the idea, therefore, calculate the normal difference in the outcome variable between the two groups, the difference that would exist if neither group experienced the treatment, okay, represented by the dotted line Q, okay? So the treatment effect is the difference between the observed outcome and the normal outcome, okay? The difference between P2 and Q. So the difference between P2 and Q is really the difference. It's not P2 minus S1. There are other things going on here. It's P2 minus Q. Okay? You follow that? So not all the effect that you see here between S2 and P2 is attributed to the treatment. Only the little piece between P2 and Q is attributed to the treatment or the intervention. Notice that the slope of P1 to Q is the same as the slope for S1 to S2. The treatment effect is the difference between the observed outcome and the normal outcome, the one expected, which is Q, P2 to Q. Here, some hairy models for you. I just want you to pay attention because in the interest of time, I'm going to show you on different notation that's easier to follow in about 2 or 3 slides. But I want you to pay attention. First, the model at the top is basically saying, hey, I have an outcome variable, okay? So here, look at the notation. First off, I sub t is the dependent variable for individuals I, that means individual 1, 2, 3, I goes from 1 to whatever is the maximum data points that you have on the outcome in time t. So time is also part of the situation here. S indicates is the group which says treatment on control group. Same, I'm using the same terminology as this graph here for this one. The I in the sigma I here, sigma I, you see the sigma I here? This I is a shorthand for the dummy variable that equals to 1 when the event described is true and 0 otherwise. The event that you're trying to describe, whatever is the event. And the plot of time versus y by group, ys is the vertical intercept for the graph. And lambda, I can barely see from here. Lambda s is the vertical intercept for the graph, and lambda t is the time trend share for both groups. So sigma, if I could simplify everything, sigma is the treatment effect. Sigma is the coefficient for the treatment effect, okay? The arrow term here over all i's over t and the time is the residual term. Consider the average of the dependent variable and dummy indicators by group and time. There's the dummy variable defining time 1, 2, 3, 4, and also for the treatment and non-treatment. And if the person is 1 or 2 or 3 or whatever. So without loss of generality, assume that S equal to is the treatment group, T equal to is the time after time, the post measurement. T sub 2, sorry for the typo here, equal to 1, that's my treatment. And T sub 1 is the same as T sub 1 2 and T sub 2 1, which is 0. Given the DID estimator, which is basically this one here, okay, is the Y, average Y for 1 1 1 2, okay, and the average Y for 2 1 2 2, okay. I'll give an easy notation next. We're still in that territory of this equation. So just look at the model again at the bottom here, okay, which define all the effects that you have. GID requires the parallel assumption. Remember, this is a different graph here. Time 1, time 2, that's the one group, that's the other group. So the parallel assumption assumes this, but you have something different here. So given that the formal definition above, however, a model with may well be more realistic, which is the one that used in the formula, the lambda, okay? I'm going to give you something more simplified. Read this over, otherwise we're never going to finish this. This is a continuation of that. It's going to take me longer than any statistician to explain to you why that sub I sub T is coming and why you end up with so many groups. But just look at the simplification. I wrote in a more simple terms here, okay? Beta 0, beta 1 T, where T is the dummy for the period. So equal 1, when T equal 2, and S is a dummy variable for group membership, meaning treatment, non-treatment, okay? And the T multiplied by S is the interaction between time and treatment. So that's my simplification. That's how I analyze the data, actually, using a generalized linear model, okay? So you have the beta 0, that's your constant term estimating the value of Y when T and S, any effect here is equal to 0. And here is the effect of the treatment S and the effect of the interaction between treatment and time. So it has a dummy for period, and S is for, you know, yes or no for the treatment variable. And the dummy for the variation of T as a function of S and vice versa. Although it's not shown rigorously here, there's a proper parameterization of the model formal definition. Turn out the grouping period average in that section relate to model parameter estimate as follows. So I did a simplification of the thing. So if you want to find the expected value of the outcome, whatever is the outcome, whatever is the health outcome you're interested in, for time equals 0, S equals 0, go no farther, that's beta 0, like in linear equation, like the value of Y when T and S equal to 0. If you want to find the effect of Y when T equal 1 and S equals 0, minus the effect of E sub I B3 0, go no farther than B1 and B2 and B3. So here you have what they estimated. B3, okay, which is this effect here, and B2 is the treatment effect, and B3 is the treatment interaction effect. If you have a significant term in B3, you cannot estimate the effect without including B2. That's a hierarchical order that you need to follow. So you need to keep, you can even drop B1, but you can't now because they're interactive. So once you find an interaction, like B3 becomes a significant term in your regression line, a multivariate linear regression. In B3, let's say Y is a continuous variable, and you're looking at time in T, S is a treatment effect, Y is something measured over time in this type of analysis. Let's say the prevalence in my study that I'm going to show to you later on, the prevalence of having preventive health service, like screening, okay? So the prevalence should change. Let's say the intervention, the S, that's my example I'm going to give it later on, is the policies, the law. Before Obamacare in 2010, more or less, okay, there was another state of Massachusetts, and the other states in New England became natural comparison that Massachusetts implemented a similar law nearly 7 years earlier. That was a real experiment. And it was a Republican governor of all places. But anyhow, so that law, it's a point in time where one state has a law that changed how you get health service, how you cover for health service. All the other contiguous states in the New England area in US are very similar. New Hampshire, Maine, and the whole area there, they are very, very similar in the demographics and the socioeconomics and the health system they had before. Everything is similar about these people. Even the language is the same. But, you know, so you create natural comparison groups. So your intervention is a law. Your outcome is prevalence of obtaining preventive screening services. And your time is time. So with that, you can estimate the effect of the policy, the intervention, by looking at time over time. It took like 5 years to look at that data. I had 5 years data on that. And then you have your interaction between time and because it takes time, right, for the implementation to take effect. So in that scenario, we had an interaction between time and intervention, and therefore all axes like T, S, and TS has to be kept in the model. But if you find no interaction between the intervention time, the intervention comes and change the outcome, and the outcome stays the same over time, doesn't change at all, then you don't need the interaction term. You can drop that term, and your effect is going to be B2. You're not interested in B1. B1 is kind of a expected maybe something would change by random chance over time. You measure that by B1. B0 is your estimate of nothing, like at a point in time, like a cross-sectional view. Okay? Is that understood, Leonardo? Good, good. So I'm not going to detail too much of it. I'm showing different examples how we came up with different expectations. Another way to look at this expected value. Go ahead, Leonardo. The time of what?
Implementation of the measure on the graphs. You don't see. We have an equation, the equation, but we don't see it on the graphs.
Oh, this equation is just to explain. It's not related to that graph. No, it's not. It's just to explain how I simplify something like that. Okay? Instead of looking at D and D, you just come like this. It's another way to measure. It's like if you're doing we didn't get too much. We get a little bit on time series. But let's say you have something like, you can always look at change over time, in which the outcome is, let's say you have pre and post measurement of the outcome. Y is your outcome. Let's say prevalence of screening, prevalence of preventive screening. Okay, so that's your outcome. You can measure that pre and post, right? You can run a regression equation in which the Y post, the follow-up Y, the prevalence of screening, is the main outcome variable as a Y. And then you write your model like treatment. You have your beta, beta 0, that's your constant. Treatment, beta 2 treatment, beta 3 time, because you're expecting some effective time, and beta 3 change. Okay? But you can also, instead of running this equation, by the way, I would also add as a predictor the Y at baseline in this equation. But I could also run an equation that I have Y follow-up minus Y baseline. That's my outcome variable. That's my Y for the regression. And I run the same model. I don't need to have that as a predictor. It's already incorporated in the change. You with me? So this is just a variation. It's not exactly explaining what I just show in the graph. It's just to say to you, this is an oversimplification that I use it constantly to measure. It's like any other linear equation. But we're going to see the singularity is what the betas represent. It's a little different, the interpretation of the expectation. The expectation for beta 2 is actually the difference between the expected value when T is 0, S equal 1, minus the expected value when T is 0 and S is equal 0. So it's really just the treatment effect. But it's still a difference in difference, right? It's a difference. This is bad because one thing came over. That's a continuation of that. So I was trying to give you a little different perspective, but the graphs came a little bit crazy. These are sigma sub 2 multiply is sigma sub 2 that multiplies 2 sub QA, sub QA. I'm sorry, it didn't come out okay, but that's all right. So you have the Y post, the Y minus pre, minus Y post, Y minus pre, but one is K, the other one is U. And who is K and U? K is the treatment group and U is the untreated group. Okay, so you have difference for the treated and the difference for the untreated. The difference between the two is the difference in difference. Okay, so you have Y for the treated post minus Y for the treatment pre minus the quantity Y for the untreated post minus Y for the untreated pre. That's your difference in difference. I was trying to simplify everything to get to this point. So, but then the type, the sigma here is really to show that's the total effect. So the beta in here, the beta here, okay, for treatment is doing that in the absence of interaction. If there is interaction, you need to also incorporate the interaction of time in the treatment. But basically, what you have in difference is that I have, and I'll show an example here, a real example. It's published. You can read the paper and understand a little bit better. The treated group has measurement of the outcome before and after, and the control group has before and after. So the difference after minus before for the treatment group, that quantity minus the difference between after and minus before for the control group, that's your difference in difference. Okay, and you always plot that to see if the parallel assumption can be negated. Basically, if it's negated, there is an effect. If it's really parallel, you don't have an effect. It should be reflected in your regression lines. That's why I showed that equation early on. Again, the effect on the top, assuming that I'm going to go over the assumption for.
Zero means no effect.
Yeah. Zero means no effect. Any detachment from zero is an effect, but not necessarily significant. You need to see if it's significant. So I'm going to go over this. The notation is pretty bad. I will fix that before you get the lecture. Tonight, I'll fix that. The notation is terrible here, too. I'm sorry, folks. Somehow, when I brought into this, it got all screwed up. Retrieving causal effects. So what can you extract? Add and subtract counterfactual values and rearrange. That's what the difference in difference is. Okay? So I will modify this. It's hard to even to follow and produce to you because it's fixed. It's a big figure. It's not a text that can change. So it's going to be, I'll skip that. Let me go. DID is an estimation and rely on cluster group level fixed effect. But what are fixed effect? Just a reminder what the fixed effect is, because they are employed to account for time invariant confounding here. Is something that doesn't change over time. It is fixed. It's an effect that's not changing as a function of the treatment or the outcome, actually. Sorry for the notation, folks. A little bit better notation here. The standard DID equation, like I showed before, can be looked at like this. So I mentioned that when I was explaining to Leonardo, that you may have an effect like that, okay? Whereas treat is treatment groups, post is 0 for both group untreated, 1 for when treatment group is actually treated. That's the mean. That means time is incorporated in that post, okay? Time is incorporated in that post. The lambda 3 average treatment on the treated is our estimated causal effect. That's your interaction between treatment and post, because post is really a dummy variable for when the treatment starts and when the treatment it's not there. And vector time for variant confounding, many confounders, it can be, this value, I forgot what the word is, in Greek, and the error term. So it could be any confounder, it could be a bunch of confounders, it could be a vector. A vector means 1, 2, 3, 4, 5 confounders. It'd be like each one of those sigma 1, 2, 3, and so on and so forth. Okay, so study design. There's an example. I'm going to give you a bad example in health, but this is a good one. A cohort description for difference in difference study of VBID medication plan. That's a kind of a medication plan implementation and medical adherence. That's published in this citation I have here at the bottom. I'll try to get the full scale of that. That's a Kaiser Permanente study. It's a group, insurance group and service. It offers both the insurance and the service in America. Many, many years, very powerful. So that's a cohort study. with a new medication plan implementation and medication adherence. So in 2013, you have non-deductible plan. In 2013, everybody has non-deductible plan. By 14, you have 1,458 people unexposed to the new deduction plan. And then you have 1,024 people exposed, being they enroll on the new deduction plan, okay? New VBID. So the other group, it's not the 1,124 are involved in a new VBID program. So that means they're paying a little extra perhaps, or something change. I don't know exactly how it's in, but I have to read back. It's been like 10 years since we've done this. So in this scenario, you have, again, the expectation of the parallel line. Clearly, the lines didn't go parallel. It's showing some effect, okay? And again, it's just a graph representation of the modal coefficients. You know what the difference now. So your expectation is that you would have an effect from B2 to A2, but that's accommodating other things. There's also interaction to be accommodated there. This is how they plotted the many possible effects. Here's a percent time with adequate medication, and here is time before and after. They're plotting every patient here, just for you to see there's change for some, but some others don't change much. Many others are still the same. I don't know how many each dot represent, how many patients, maybe hundreds of patients, but clearly there are changes, dramatic change for some patients. There are about, 80% adequate medication went to lower, they went down. So the way they analyze that, I'm not going to get into that. They use repeated measure ANOVA, GLM procedure in SAS. They use repeated measure linear regression, use mixed procedure because they probably had a random effect for time. And they use propensity score. None of these topics are a topic of our conversation. I decided not to present the thing. So let's see if I can, before I go, I give an example. Just go over this. So you have the group so-called unexposed and the group called exposed. And the unexposed group, you have quite a few people who went from very low 0% to about 40%. And also you have some people around 20% went down to close to 0%. So almost like these two groups cancel off each other. That's the unexposed group. But also there's some unexposed group in the top, and they went from about 70% to about 69%, 67, 68. So it went down a little bit. The one on the top. So the ones on the top, the unexposed, which is the little dot with an empty, like a white circle. So on the top, they stay more or less the same. At the bottom, some went up, some went down, nearly equidistantly in a graph. So in the unexposed group, on average, about stays the same. When you look at these graphs, these are hundreds of patients, each subgroup here. Okay. Whereas the intervention group, the exposed, let me see, some went up, some went the same, some went down, some stay. I don't see, at least graphically, a major effect. So you really need a very complex regression. The sample is pretty small here. Plot of pre-post adherence by exposure group. It shows that in this case, actually, now that I know sample is 30, I don't know if it's clinics. I think it's 30 clinics. Yep. So I see very little effect of the new program on changing the adherence, which is the measurement here. You're interested in, or they're interested in what? Implementation in medication adherence. Yep. So that's what the experiment is. So I'm not going to show that. Read the paper. There's a lot of graphs over there. I'm going to show you an example that I designed to evaluate the so-called Mitt Romney healthcare that preceded Obamacare by about 6 to 7 years. Because the Obamacare is not really an idea from Obama, it's an idea from Mitt Romney. It's exactly a copycat what he did in New England. except that he did not impose a lot of restriction on the private sector. And there was a lot of fight on Obamacare because they wanted to implement laws in ways that was very anti-freedom of market type of thing. Say, almost constraining private sector from doing the right thing. So, but they are very similar, except for that, the program's idea was the same, very similar. So I evaluated that program when I learned the fight for 1 year policy-wise in the United States in 2010, 2009. So I designed that study looking back from 2003 to 2009, surveillance system. I could have done a regression discontinuity here using year as a mark, a cutoff, but I did a little different. We used a difference in difference design, okay? So we examined the impact of the Massachusetts health reform and the public health component, the prevention component, on change of health insurance coverage by perceived health, okay? So we're looking at the health insurance itself. Does it change because of law? It doesn't mean it's going to change. You can create a law and people still have the same coverage as before, okay? Or does it change the outcome once the insurances start changing? Okay, or like preventive service, perception of your own health. Are you feeling better or not? So we look at this variables over time. So we use 2003, 2009 behavioral risk factor surveillance system. We compare health insurance coverage before and after implementation of health reform law in Massachusetts. That's my treatment group. And I use the other contiguous states called New England. America is very geographically, New England is like in northeast of Brazil, like Pernambuco, Paraíba, Alagoas, Sergipe, and Ceará, but very wealthy. They have the highest quality of life possible, okay? But they're all very similar. Very strong government influence, but not so strong like it is in a socialist country. But, you know, so they have very similar laws, private sector, capitalism, everything is balanced in a very structured way. So you create a natural comparison group between the state of Massachusetts and the contiguous states. You follow that? So we compare insurance coverage before and after implementation of health reform law using difference in difference and difference in difference in difference methods to examine the overall trend and the underlying trends in insurance coverage stratified by levels of perceived health status. We did all the analysis. I'm presenting this one, but there are other analyses. There's one on preventive service, which I will bring it tomorrow. Tomorrow I'll bring more examples. I'll bring another one on preventive healthcare service. So here you have, again, New England and the other New England states. So think about it, what we just learned. I will have a Y, that's my outcome, let's say here in this example here, just insurance coverage itself. Because the law was passed, it didn't mean the health insurance coverage would change. It's the expectation, because the law in America does not force you to have or not have. It's just to create incentive for having healthcare insurance by the states, not by the state, but subsidized by the states. So insurers will benefit as well as people. So there was no knowledge back in 2002 whether this thing was going to work. So the first examination is, does healthcare insurance coverage change or not? And then does it change health perception of the patients engaged in covered or uncovered? So that's what we did here. So the proportion of adults 18 to 64 with health insurance coverage increased more in Massachusetts than the other New England states. The other England states did not have the law, remember? They are the natural comparison group. So in Massachusetts, this change went from whatever it went to where the change, the difference between them is 4.5. It could have been 3.5% coverage to 5.6% coverage. That's the confidence interval around the estimator of a prevalence of 4.5. Okay, that's how many people became more covered. So from 2003 to 2009, in 6 years, the insurance increased the number to be covered around 5%. Well, 5% is a small number if you have 0% coverage. But if you already have, in the state back then was like 70, 80%, covers in most states, or some states even have a 90% or 5%, a substantial increase. Okay, just to remind people in Brazil who are watching this thing, in America, since 1964, every poor person has complete coverage of their health. 1964, we are in 2024. So that's 60 years. Every poor person defined as below poverty line, which is much higher than here. Poverty line is a family whose husband and wife are making just minimum salary, but they have 2 or 3 kids, 2 or more kids. They only have 1 kid, they're not, because they can support. If they have 0 kids, they're doing well. Okay, because the minimum salary in my state, vary by state, it's about $13 per hour, and you work 8 hours a day. Make the account. Okay, so everybody has health insurance more or less. So health insurance coverage is very high, even before this program in Massachusetts or before Obamacare. It was hovering around 90% across America, 80-some%. Okay, for those with higher perceived healthcare need, the post-reform proportion significantly exceeded pre-reform. I'm not showing the prevalence, but that's the people who have perceived healthcare need. They perceive they have more recent mental or physical unhealthy days or activity limitation, LDL, ADL. The post-reform proportion significantly exceeded pre-reform. So you went up because people start perceiving a need once you have access to coverage. Groups with higher perceived healthcare need represent the disproportionate increase in health insurance coverage in Massachusetts compared to New England at 4.3% for fewer than 14 LDs to 9% for 14 or more ELDs. That's, the activity limitation days. Conclusion: on the basis of Massachusetts experience, full implementation of the Affordable Care Act for Massachusetts may increase health insurance coverage, especially among population with higher perceived healthcare need. Okay, so that's what we found. Tomorrow I'm going to show how it affects preventive service. It went up, which was a good thing. So here you have the lines, like I showed to you. You have that's another example. That's the Florida healthcare policy. Okay, I'll bring a little bit more on this experiment tomorrow. Tomorrow's the day that I'm going to present implementation designs, how do you evaluate implementation, and I'll show some example in more details, more graphs and things like that. Okay, here I'm showing another example. That's a Florida healthcare policy that was implemented and is published here by Dimitri. I think it was in the 90s also. The Florida implemented change in healthcare policy aimed at the elderly that improve a health outcome like free flu shots. So back then, before COVID forced the federal government to spend a huge amount of money making flu shots, everything nearly free. But the health insurance coverage in America is very high, but sometimes they don't include flu shots. You have to pay out of your pocket. Small amount, but it may be significant for people who have no money. So logical control is the young in Florida, but other factors unrelated to Florida new policy might affect the health of the elderly. For example, change in Medicare reimbursement. Another type of DID analysis would use another state as the control and use elderly from the non-policy state as the control group. So that's what was done here. The DDD estimates start with the time change and average for the elderly in Florida, and then nets out the change in means for elderly in a control state and the change in the means for the non-elderly in the treatment state of Florida. So you end up with those possible DDD. Look at this paper. It gives you a very good idea. Tomorrow, I'll try to bring a little bit more detail, not just these are examples, but just basically look at the top. DED is 5 minus 10 minus 4 minus 6. This is the difference on the top one in the treatment and the control group. The Florida versus the contiguous state that you use as a control group. And then you have the effect, okay? You have a minus 3. And then you also have another example that you have the D, and D, okay? Which is the DD that you found minus the difference for a subgroup of elderly and the young. Within the bigger effect, you still can break that down in elderly and young. You end up with a DDD. You following that? So it's the difference in difference in difference. You're going to have treatment effect post minus pre for young, post minus pre for the old, and this is going to be substrated into Florida and the other states. So you end up with 3 levels of D&D, and you just take the difference between them. And that is done through analysis based on regression. You with me? So, and that's what I want to show you tomorrow to you, the regression we use for my evaluation, which also does both D&D and DD&D. Okay? So that's a very important method for estimating the effect. Here is the little bit, I mixed them up. This is a little bit of the previous, the one I gave. I'll give it more detail tomorrow. But you can see the pre and post reforms values, and you can see clearly, even the raw without analysis, you could see there are some differences. For example, Hispanic population, or Hispanic, let's say race, ethnicity, gender, age groups, you can see some change, and characteristics of non-orderly population in the 2 groups, pre and post reform. This is just the gender, the basic statistics. So because if that's changed, it might also affect your outcome. So you want to make sure, like in a randomized trial, that you have, if these things have changed, could explain your difference. But even if they are changing dramatically, like Hispanic from 81.6 to 78.3, I used the Hispanic dummy variable to define race ethnicity in the model. So you adjust for those changes. So those changes could not explain the outcome I found. But this is a good way to show through the table that you have potential confounders of your relationship, because these things change. Any of those demographics affect your coverage, your healthcare coverage, because race ethnicity is a marker of your income level in America. Age too. The younger tend to have no coverage. The older have to have coverage, right? Male, female. Males are more likely to have healthcare coverage than female because they are more in the workforce, even in America, than a female. So all these factors affect the outcome of your interested healthcare coverage. So you need to look at that, and your first table is like you're doing a randomized trial, shows your control in the treatment group. Here is controlling treatment, pre and post, show everything. So you can clearly see some of these variables could have confounded the association I found. They need to be adjusted in the model. That's what I wanted to show to people. How are you doing on time?
11:35.
Okay, so we have about 20 minutes. Okay, so here, sorry for interceding this Florida example. It's not supposed to be here, but it's very similar to the one I did in Massachusetts. Anyway, here's the Massachusetts continuation of that. Here you have change in health insurance coverage in Massachusetts versus the change in New England. You remember when I said that the counterfactor here would be the parallel line, okay? So the Massachusetts is the blue line, and the other states is the red line. The parallel line, you have a line that starts where 88.7 start, but will be a much kind of a less inclined line. That's a parallel line. You don't even need to calculate, do graphics. You can see there's a real effect here. It goes from 88.7 to 93.9. So, by the way, look at this is a state that already had healthcare coverage of 88%, 87% of the population. Very comparable to the 2 groups, right? 88.7, 87.2, very close. But the one stays about the same, maybe changing a tiny bit up over time. The other one changed more dramatically. Okay? So that's what the law did, which means the law is doing what it's supposed to do. Some of the laws don't go like that. Here are some of the difference in difference calculations. This is the raw without the adjustment. Okay? Health insurance coverage and change between pre-reform and post-reform in Massachusetts and all the New England states stratify by proxy measures. So I stratify on the proxy measure, which are the perception of limiting days, because that's a major confounding. If they're in the start, the people feeling bad, they're going to affect your way you go after health insurance or not. And it did. Okay. But then in a regression, you throw that into everything goes into the regression, and you have plenty of data. That's the BRFSS data, thousands of data collected every year for any one of those states. So you have tons of data points, people covered, not covered, covered, not covered. Question, Luis?
In Massachusetts, you had an increase in mentally unhealthy days with the reform.
Yeah, that was going on already. Okay, so it's not.
That's not the expected result, is it?
Well, actually, we put in that here because we wanted to make sure that this secular trend would not affect, because the main variable we're interested in, does health insurance cover increase or not? Okay, and why? Because this is not a law that says obligated like was Obama, more or less. It's a law that say creates incentive for people to be covered to the private healthcare system, and insurance system has an incentive for them, and it did. It went up. After we did that, we even go up. 4 years later, I think it was nearly 100% of the people in Massachusetts were covered before Obamacare. And their law is less aggressive than Obamacare in some areas. But then you have some secular trends already going on. Plus, having more healthcare coverage, more people have unhealthy days to look for more healthcare coverage. So you know that these things, you have to think a priori about all those things before pulling that into the models. I hope you guys see that, what Luis was saying. Mentally healthy days. This is the Massachusetts group here. Look at the mental unhealthy days. Okay? Yep. So the mentally unhealthy days for more days, 14 days or more, went from 91 to 83, from 94 to 89. Okay? Well, the difference between them will be a positive difference, because it's going to be this one minus that one, the post minus pre, so it went up. So I was explaining, Luis, that you need to think about those variables ahead of time. This could be a reflection of secular trends, but also could be the fact that you have more covers now, then the people have more needs, look for the covers that didn't have before. Exactly. And so that was an a priori hypothesis we already had. And that's why we're breaking that down along those lines. Okay. We expected those change for more physical unhealthy days, more mentally unhealthy days, and more activity limitation days. Okay. So that means the coverage, in a way, you can interpret that, oh, maybe secular trend adjusted for already. Or it could be that this is an expectation to you, was an expectation. Not as strong as the expectation that insurance will cover more people. And that's the main expectation, because there's no guarantee this law will engender an increased coverage for the population because of the way the law is created. Okay, so this is all measured. And the effect, it's a little bit of that effect also is happening in the other state, but less stronger on this state. So in a way, the unhealthy days for mental, the unhealthy days with physical and increased physical limitations is also an expectation we had, but also because we're looking to that in the strata, if that happened to be a secular trend, it was not a factor here because we analyze it within each substrata. You follow that? I remember 2 ways to adjust for confounding. You stratify on the variable you think is a confounder, right? Or you adjust for the confound as an average measure across strata on the third variable, which is the confounder. So that's what you have in this measure analysis. You got the paper. I'll go over a little bit more tomorrow with an example of how the health insurance affect preventive care. Okay, and then I'll give a little bit more of the equations. Here you see a little bit of the difference in difference, difference in difference in difference. You see their values, and there's a notation here you can find out. Post-reform minus pre-reform, Massachusetts minus all the New England, and then 14 days minus less than 14 days for any one of the difference within the D&D for the states and the time. And that's called D&D, theoretically. Here a little bit more on that with the different notation that I gave you before. You can see some books and papers calling B and A. It's the same ideas here. Okay, you can see those effects that I showed to you before. That's how they are calculated, but through a regression. This is a simplification, okay? And the crude values, okay, unadjusted, they're all unadjusted. You can see the word unadjusted there, okay? There's also an adjusted value, okay? This is the adjusted now. You see the same table we had before, now is adjusted, changed a tiny bit, didn't change a lot, but changed somewhat. And that's the value, same ideas. How you calculate those, I'm showing little by little so you can see how that sausage is done. This is how we fill in the sausage, okay? Romney Care for Massachusetts versus the other state. And the paper is published in American Journal of Public Health. Can see that. So I will end this shorter because I wanted to present something very important to you. It may take longer than, and I'll hopefully not. If they ask me a question, maybe, but it's an example. Maybe we do quickly too. From stepwise design as a real study that I break down in detail. Tomorrow I'll break down in detail this Massachusetts stuff for you. We can go over in more time because we are very close to the time we need to finish anyway. I want to give you an extra break. Real 15 minutes. Before is only 10 minutes. We'll give you 15 minutes so you can, after 2-3 hours, people got really tired. I promise the next hour is going to be 15 minutes. Okay? 15 minutes plus 15 minutes will be close to 11:30 when we finish this whole thing. Thank you. You've been a great audience.
Welcome back, everybody. Like I said, in this course, we look at evaluation of intervention effectiveness. I think I cover the gamut in terms of evaluation design that you could deploy to evaluate interventions in primary care, public health, big policy change, and so on and so forth. You have a lot of tools now, not in detail, but the overview, and in some of them I gave a lot more detail. And one specific design that I'd like for you to consider for public health practice or healthcare delivery is the cluster randomized design, especially the step wedge cluster. But without giving an example of a cluster design, it's hard to see it. So I'm in over 20 or 30 minutes. I will go over a clear example of this analysis. There's a citation, there's a reference, and I go over every detail, okay? I'm taking advantage of somebody else's lectures to do that, okay? That's Daniel Vodila from WHO, World Bank Special Program on Research for the UNDP. That's the UN, United Nations, okay? So we're going to introduce here the strategy for data analysis depend, as you know, on the design. You can have completely randomized, pair match, stratify. You can also have individual randomized, like traditional randomized clinical trials, or the cluster randomized design. Well, if it's a cluster randomized design, you really have to incorporate, as I mentioned to you all, the intra-class correlation coefficient that accommodates the proportion of between variance to the summation of between plus within variances. Remember that, right? We're going to see that. So we're going to go an analysis by ITT or PEP protocol. This is a terminology I use in the randomized trial, the first lecture, means intention to treat. Meaning, if I allocate you to the treatment randomly, allocate you to the treatment group or to the control group, you remain treatment. Even if you change, I don't care. You are the treatment and you are control. It's called ITT. Or PEP protocol, I already delimited in my protocol this was going to happen, or something similar. Then I'm going to go over the baseline characteristics of treatment groups that should render the two groups comparable. We're going to look at crude effect of treatment. We're going to look at effect of treatment adjusted for possible confounders. And we also look at effect modification and stratify analysis. And other analysis like secondary sensitivity and subgroup. This is all summarized. But this is a good example. I want you to read the paper, but I'm going to go in more detail than I gave it so far in any other example I showed today, okay? So here again, this is a randomized trial. We're going to look into intention to treat principle, meaning all patients included in the analysis in the group to which they are randomized, even if they did not receive the allocated treatment, they are still treated as treatment group. Let's say they are in the treatment group allocated randomly to the treatment group, but they failed to show up or are part of the study but did not receive the treatment because somebody forgot to give the medication, for instance. You're doing a clinical trial. I'm still going to treat that person as a treatment. And that's a bias, but it's a kind of a not so bad bias because if the treatment has an effect, I'm missing the opportunity to increase my power for that effect. So I have a smaller N on my treatment group, okay? So in that way, I fail to reject type 1 error when I am right? So that's a type 2 error. Per protocol analysis, randomized subjects who are not eligible are excluded. So that's another principle here. Randomized subjects who are non-eligible are excluded. We're not going to include any eligible because something changed. So these are very basic principles assumed here. Reasons subject could be excluded from a trial, moved out, dropped out, lost to follow-up is the most common, but it's also non-eligibility, non-compliance. Other units did not attend all visits in this design. There's a paper on that. You can read it. Advantage of the ITT, inclusion better if the trial is finding out to be extrapolated to future clinical practice in which eligibility for a given treatment is less strictly defined. So you benefit by doing the analysis like that. That's conservative. It's a better way to look into that. Sometimes the intention to treat is not possible, can be relaxed when outcome is not known.
like in withdrawal. I don't know what's going on with that person. When a subject withdraw before the treatment start, check if the number is reasonably similar between groups. We want to make sure that you have a documentation of groups being treated, not treated, and leaving before even I allocate to treat and not treat. And find out why they left and document that. In phase 1 and phase 2 clinical trial, we explore property of treatment and idealized condition. This is very important. Analysis per protocol in treatment. Remember that by group analysis, withdrawn, completing the trial, not receiving, you need to construct a flow chart. Like I say, document this well. It's very important to document randomization, eligible, not eligible, assignment to group, withdrawn, complete the trial, not receiving or compliant to the trial. So you end up with something like that in your flow diagram. In a typical randomized, either at the individual level or the cluster level. You end up with something like that. Okay, you have your assess for eligibility, exclude those who are not eligible, include those in a randomization. At that point, you kind of allocate them to intervention or intervention group, and then you follow them up. You start seeing loss to follow up, and you may discontinue intervention because you create a rule, ethical rule. If it's a treatment that's causing a lot of tremendous effect, positive effect, you want to stop the treatment because you already have enough power in your analysis to justify the treatment. You don't need to proceed because the others are being excluded from the benefits of the treatment, the control group, right? That's one way. There are many other ways you can discontinue an intervention. Analysis, excluded from analysis as possible. You need to document how many excluded from analysis. Missing values, the values were supposed to be measured, were not measured, or measure on the individual but not entering the data set and lost. Everything could happen in real world analysis. So in this scenario, you have this study. This is a randomized control trial. Glucose, insulin, potassium, GIK infusion, and a widely applicable low-cost therapy has been postulated to improve mortality in patients with acute ST segment elevation myocardial infarction, called STEMI. Okay, so in cardiology, you have your QRST lines in your heart, and the ST is usually the segment that you pay attention to because it indicates that you're prone to have an infarction, or you already have an infarction. It'll be elevated, but also you have a Q line. They're not saying a Q line, they just say ST segment elevation myocardial infarction. They're considered that all myocardial infarction here. Objective to determine the effect of high-dose GIK infusion on mortality in patients with that. So the outcome is mortality. The selection of the study population is patients with STEMI, S-T-E-M-I. Okay, that's your segment of the population of patients you're studying. And your outcome is death, mortality in patients with STEMI. And you're doing GIK infusion. Every patient you have, and then you have a control group. It's a randomization. So let's see how it goes. Randomized control trial conducted in 470 centers worldwide, involving 20,201 patients with STEMI who presented within 12 hours of symptom onset. Sorry for the typo here. It's not symptom, it's symptom. Main outcome, mortality. It's a main outcome. The other one is cardiac arrest. The other one is cardiogenic shock. The other one is reinfection after 30 days after randomization. So any one of those is an outcome. You can do an analysis for each individual outcome, or you can do an analysis, all of them combined. So here is your trial, your breakdown. 20,201 patients randomized, 10,110 assigned to receive the usual care. That means these patients are not receiving nothing. They are receiving usual care. Okay? They receive usual care. So what the usual care is, it's a medication to facilitate dilation of the coronary arteries. If they have any sign of pain, like nitrate, likely, they're probably taking some diuretic if they have some minor hypertension. And they're clearly taking medication for the so-called ST elevation if it's affecting arrhythmia. So whatever all the necessary treatment they're having at that point. It's not like they're not having anything, but we're adding the GIK, the glucose, insulin, potassium, and the other group. Okay, that's the only difference. So it's 10,000 one group, 10,000 more or less in the other group. Then you have loss to follow up after 7 days, 30 days. You end up including, for primary analysis, comparable size groups of just slightly over 10,000 people in each group. So the baseline characteristics by treatment groups, you're going to observe that comparisons made by assessing prognostic relevance and the difference observed, not using test or hypothesis, just compute sample statistic mean standard deviation by treatment groups, compare baseline characteristics between treatment groups to discover possible confounder. If there's a lot of imbalance between the groups and those other variables, likely they will confound your associations between the treatment, the GI key, and the outcome. So you want to control for that. So here's typical randomized trials. You always show a table like that. I showed something like that in the difference in difference, remember? Because I had expectations those things will affect anything. So you have a selected baseline characteristics, the treatment group, the usual treatment, and the GI key, the new treatment. And you can see that age, gender, type 2 diabetes, very important predictor of coronary heart disease, weight, body weight, systolic, diastolic blood pressure, heart rate, and the killer class at randomization. This is a classification for your level of severity for the heart muscle. Okay, I'm not gonna get into that. That's a clip randomization. If that's a start, you have a very bad killer class. That means you're more prone to have a heart attack. So you want to adjust for that. So you want to see the effect only of the treatment, not the effect of that. So any of these variables could affect your outcome, especially if they're imbalanced. But this is a randomized trial. So randomization should render any one of those variables similar across group, and it's doing that trick. Look at that. Age, 12.5, 12.2% in both groups. Very similar, right? Nearly identical. So the other one is 22.4, 22.4 by chance. This is what happens when you have a large number. You randomize, you render the two groups identical. The only thing different between them is treatment. Everything else is going to be very similar. Should I adjust for them during the analysis? I would, even though there's no chance. Remember, you heard that here in this class, for a database confounding effect. There's no reason to believe there will be database confounding effect by any of these 8 variables. 1, 2, 3, 4, 5, 6, 7, 8 variables here. They should not be database confounder. But what if biologically some of them are strongly related to the possibility of your treatment and your outcome? So they are not going to be a database confounder easily because they are equally balanced, but maybe something has happened. Maybe are what we call joint confounding. So many analysts look at that and say, I should not adjust for these variables. They are identical in each group. It should not matter. But sometimes you have a joint confounding, 2 or 3 variables come together and confound the association between treatment and the outcome. So you may adjust. It's your option. Remember, every time you throw a lot of variables into a regression, you have terms, so regression terms. And each beta for each term puts a pressure on your variance. So your variance tends to grow big time. So the more variables you have, the less precision you're going to have in your estimator that you estimated using the regression, the estimator of the effect, which is the beta for the treatment effect on the outcome. Okay. So crude effect of treatment. Let's look into that. You estimate the magnitude of the effect of the outcome measure and compute a confidence interval. It's better than a p-value because it informs you what's the real possibility of the effect. You want to do that. This is a clinical treatment, right? You want to see what's the effect, the real effect. P-value is going to help you to make a decision, but confidence interval does the same job. If your confidence interval includes the no hypothesis, then the p-value should be greater than 0.05. There's no other way. That's mathematics. So you can do both with the confidence interval. Okay. So estimate the magnitude of the effect outcome and compute a confidence interval around that magnitude. If the outcome measure can be 3 types, categorical, continuous, or time to event. Time to event is very much used in clinical trials. That's survival time, time to death. Okay, continuous variable, cholesterol levels. In this case, is death. So it's a categorical, it's a binary, death, yes or no. Have a cardiac arrest or not. Remember the outcomes we had, like 4 outcomes possible. Multiple levels improvement, mark, some, note, that's a possibility also. So you have categorical, continuous, and time to event. Let's look into that. Statistical method used in the analysis will depend on the type of outcome measure as you know it. Okay? So here you have the 30 days death, non-fatal cardiac arrest. That's your outcomes, right? Remember the 4? We're interested. Cardiogenic shock and reinfarction. So the usual care group has this prevalence, these proportions here. You can calculate the relative risk between this proportion because this is coming from a follow-up of over time. It's a randomized trial. So that's probability, that proportion is a probability of becoming the event of interest among those who are at risk for having that event over time, right? That's your risk. So you have the risk in the usual care for death is 9.7 and the risk in the infusion group, which is 10.0. And you have the relative risk of the GIK infusion by the usual care. That's going to give you a relative risk of 1.03 with a confidence interval of 0.95 all the way to 1.13. Well, that includes a null hypothesis of a relative risk equal to 1.00. The relative risk or risk ratio of 1.00 means that I expect, based on a null hypothesis, that the risk in the infusion, GIK infusion group, will be the same as the risk in the other group. As you know, arithmetically, if the numerator is equal to the denominator, the value of that is 1. So your null hypothesis, the value of relative risk equal to 1. And the confidence intervals does not detach from that. It actually includes the 1 right in the middle. So that means there's no effect of GIK infusion on death in this follow-up of randomized people into treatment and control group. P-value is very large, 0.45. Likewise, there's no effect of GIK infusion and no fatal cardiac arrest. Confidence interval also include 1. There's no effect of the intervention on cardiogenic shock. This is crude analysis, folks. It's not adjusted for anything, I believe. It's 0.338. Reinfarction, the same thing. So you have all the confidence interval, the actual measure, and recall that in a study is like a sample of the truth. Okay? Every study is a sample of the truth. So the relative risk is an estimate of the true risk out there. If I could repeated trials over and over and over and multiple times, the confidence interval would be like that. And the probability of finding this value or an extreme value is more extreme than that is the p-value you see on the right. Now we're going to look at the effect of treatment adjusting for possible confounders. What are we talking about? We mentioned that variables imbalance between groups are naturally data-based confounders. Variables related to the outcome based on biology or socio-economical, behavioral, ecological knowledge also considered to be a potential confounding variable. So adjusting for confounding include confounders in a multivariate model. We have to account for collinearity, very important when doing a regression. If 2 confounders or confounder plus the main exposure treatment are strongly correlated with each other, they create collinearity, meaning your model be unstable. It's a phenomenon. You have to estimate that mathematically. That's not focused on this analysis or class, but remember there's something called collinearity. It's going to make your crazy values for the relative risk on this case. You may have called it relative risk of 900 or minus something. Okay, it's crazy. So confound is not as important as in observation study and randomization, because randomization rendered the 2 groups similar. So it's almost like inexistent if you do good randomization. If you have more than 100 people in each group, likely randomization rendered the 2 groups similar with every variable except the treatment. So effective treatment adjusting for possible confounders. You also look into this class of randomization, which is known to be associated with mortality after myocardium. So you're going to produce an adjusted measure of the association between treatment and outcome, adjusted for all these
confounding variables. We're also going to look into effect modification, is when the variables actually modify the effect of your treatment. That's different than confounding. If you find effect modification, you should not drop or keep other variables in. Bottom line is, once you find interaction, you should evaluate interaction or effect modification before you do confounding, because this variable cannot be dropped or not because it's not a confounder. You have to keep that variable and the main exposure variable together, because they are interacted with your main exposure, your treatment. So that's an interactive or effective modifier, interactive variable effect modifier. So there's no homogeneity between centers to pull the effect over the centers. So you need to consider effect modification always. Other analysis, it's called secondary sensitivity and subgroup analysis. Okay, secondary analysis is when you are doing an analysis of something that was not your main objective. In this case, they're looking to phlebitis and hyperglycemia, not your main hypothesized study. So your main primary outcomes were death and the other events, but here you're looking to significant phlebitis and hyperglycemia. And guess what? There's a relative risk effect, okay? The GIK infusion group has a risk that's increased of significant phlebitis. So that's attention. Hyperglycemia too, it was very much in one group versus the other is pretty high. Sensitivity analysis, when you modify your crude analysis or adjusted analysis, assuming that you're losing some information on the observed variables for the people in the study, or you're losing people, say you eliminate 20 people, like the loss to follow-up, you need to estimate more or less how many people are lost. What if all these follow-up people lost to follow-up that I had? Let's say I had a study with, like in this case, 10,000 group, right? Let's say I lost 1,000 people, which is not the case here. Well, if I throw all the 1,000 people in the exposed group as opposed to unexposed, because they are lost before randomization, how's that going to affect my result? That's a sensitivity analysis. You simulate how the people who are missing for your analysis could have affected your results, okay? In subgroup analysis, anytime you analyze something by subgroups, okay? So thrombotic therapy, usual care group versus the other group, you see the proportions, you see the p-value for difference between these proportions. That's a subgroup analysis, okay? And then you have your discussion, strength and weakness of the trial, consistency with data from outside the trial. That's how you write your discussion, consistent with all the biological knowledge, implications for clinical practice, implications for research. In your presentation, you need to describe the protocol and deviations from the protocol, always show your percentages, state result in absolute numbers, not only 50%, put the actual counts so people can see what the prevalence or the risk or the proportion that generate the measure of the risk is. Present statistics in sufficient detail to permit alternative analysis by those reading your paper, okay? Tomorrow, I wanted to give this because tomorrow I want to go over the same idea that I did here for the randomized trial. We're going to talk about the cluster randomized trial, and I'll give a full example here, okay? So we're going to do that tomorrow. I'll let you go. Tomorrow's going to be implementation designs, give an overview. There's a little bit of a language and terminology I want you to be aware of. And then I'm going to give this example of the cluster randomized trial. I showed the example of a individual level analysis. Now I'm going to show a cluster randomized trial, okay? See you tomorrow. You'll be in wonderful audience again, because you don't ask questions, only the people here in the auditorium will ask a question. Thank you. Take care.